Don't have the greatest cases this week, although this is actually kind of interesting. I can't confirm if the imaging findings we're seeing are secondary to this or something else. This is a woman from the Middle East who is a non-smoker. I'm sorry, this is not projecting very well. Who's a non-smoker, lifelong, and has a history of, in a rural area somewhere in the Middle East, cooking extensively over like hot oil and kind of using dung fires and biomass for cooking. And she's had issues with obstructive pulmonary disease for a long time. And her underlying diagnosis is obstructive pulmonary disease secondary to inhalational injury from this biomass fuel cooking. That is her ongoing diagnosis. It's been like that for a long time. I don't know whether it's true or not. The interesting thing, and whether it's related or not, is she has some pleural plaques. Again, I'm not 100% sure how she got these pleural areas of pleural thickening and plaques, but she has these scattered nodules. Now, this is a long time ago. This is about, I think, a study from like 2006 or 7, and this is a more recent study. And you can see that these nodules, she's breathing, have grown in number and size and kind of started to coalesce. She's actually also has, again, these pleural plaques, which have, some of them have started to actually calcify. And, I'm wondering if these are due to her underlying inhalational exposure of whatever she cooked over, kind of like almost like a pneumoconiosis picture. And there are reports of this in the literature. Of course, she has these kind of eggshell calcified nodes around, which could be seen with various inhalational injuries. I mean, it could theoretically just be TB, and she has these nodules, but these nodules have been growing and coalescing over the years. She supposedly doesn't have continued inhalational injury, but again, this is more of a consult thoughts to hear from other people. I mean, if you told me this person was a coal miner or worked as in a mine somewhere, I'd have no issue calling this mixed dust disease, probably with combinations of coal and silica. But anyways, thoughts, comments?
What about just a funny sarcoid, given the eggshell calcification and then these subpleural? A lot of those nodules look perilymphatic.
Some do. A lot of them are subpleural. Yeah, I mean, the nodules have been growing over the years. I don't know. She's like 82 years old, 84 years old. I mean, it could potentially, that could be possible. Maybe it's just related to sarcoid. But yeah, I don't know.
And she's also got a lot of, I mean, you can see she's got quite extensive mosaic attenuation. That's presumably her small airways disease. Now, those plaques are interesting because they don't look like pseudoplaques. They look like true asbestos.
Yeah, no, they look like true plaques. And it's just an odd case. Again, just a woman that was cooking using coal, biomass, whatever, for a long time in rural parts of the world, and as a lifelong non-smoker, which is kind of, and I think the large and small airways injury is quite apparent due to the bronchial wall thickening and mosaicism. Anyways, I don't have a good answer on this. I just thought maybe it's some sort of inhalational process. But anyways,
I actually like those for pseudoplaques. I've seen a number of co-workers lately who have rounded opacities that seem to hang on stalks from these upper lung pleural surfaces, and they're deep in the lung, but they sort of have an attachment to the subpleural thing. And I see those in conjunction with pseudoplaque. So I think this could be really pseudoplaque, and a lot of these nodules, resemble these nodules I've seen in co-workers in terms
Yeah,
of having a
that's exactly
sort of finger-like extensions inward.
because I was thinking coal, just from her cooking in a hut they describe, cooking over coal and all this other stuff for decades. But then the rounded nodules, I was wondering, maybe, I don't know of coal itself giving you the kind of, wondering if there are other things she was inhaling. Anyways, just kind of an interesting case. This is another, haven't had the most fascinating cases recently. This is just a patient who has undergone a bone marrow transplant and has been having worsening graft versus host disease. And, now we're kind of recognizing, or have recognized, that, pleural parenchymal fibroelastosis is kind of one of these complications we're seeing associated with bone marrow transplants and patients with graft versus host disease. And so presumably this is a case of, although we don't have path proof, and she does have signs of the mosaicism and the scattered nodularity, but I think there's these confluent subpleural areas of fibrosis with areas of pleural thickening kind of extending into the lung. So I think it's a nice case of post-BMT pleural parenchymal fibroelastosis. Why it develops as part of the chronic or the graft versus host disease, or why it develops in this subset of patients, I'm not entirely sure. But I mean, it's well recognized in literature. I don't know, people might have better ideas as what the underlying cause is in these patients.
Well, it's probably, you see this in a small percentage of lung transplant recipients.
I have a lung transplant case too, recently as well.
In that case, it's host versus graft, but presumably that's the pattern of injury that develops in those particular patients. And it seems to occur at about the same frequency. It's somewhere about 5 or so, maybe 10% at most.
Oh, in lung transplant? Because I was reading, I just had been reading on this recently, and they were saying that it's more, I think bone marrow is more common than lung. Like bone marrow is like the 5%, and lung was less common. But again, that was one paper I read.
I think maybe GVHD is so common.
Yeah. So you think it's actually a process? So it is actually just the GVHD that's causing this kind of underlying pathologic process.
Yeah. And I think that's because it's, again, with the lung transplants, it's just host versus graft, but the injury is pretty much identical.
Yeah. And she has known GVHD, so that would make sense. And then the last case I was telling Travis about the other day, this is a patient, just to go along with some of this smoke stuff, patient with a history of a Takayasu's arteritis, graft versus Takayasu's arteritis with this is right case, and had an ascending aortic replacement, and you can see that the left subclavian's gone. There's all this soft tissue left common carotid. She's had a stent over this very ugly aneurysm that developed in her descending thoracic aorta. What was interesting, she had this, she came in with increasing chest pain, and she had this kind of CT of the aorta, and scrolling through it, there's just kind of this, you scroll through it, and there's just this smoke-like appearance here sitting in the ascending aorta, and I really thought it was nothing. I thought it was just kind of just contrast. This is where the anastomosis of the graft was located. I just thought it was kind of a high velocity jet across the anastomosis. Then we got a delayed image, which is interesting because that most of that goes away, but there is a residual little linear focus here within that, which is much smaller than what we saw before. Just this tiny linear focus, which it's difficult to really tell exactly what it is. It's probably a little bit of thrombus attached to the anastomosis, where the graft was kind of sutured in between the anastomosis between the graft and the native aorta, but kind of masked by that. You kind of saw a hint of it, but I don't think anyone would have called it on the arterial phase. Another possibility was that it's some little focal intimal injury. But anyway, it's just kind of a, and then the other interesting thing in this case is where you can really see the enhancement of the wall within the vessels as well in this patient with Takayasu's. So kind of a case where the smoke was hiding the underlying clot in this patient. So, because here, I mean, you really don't see that well. You just see this kind of haziness. But all right, those are my cases.
Thanks, Seth. All right, David or Travis?
I can show a couple.
All right.
So this is follow-up of the case of Erdheim-Chester that I showed a few weeks ago. That was the person who had the, surprising to me, retrobulbar infiltration, both eyes, and had nice halos around the kidneys that we could barely see on the bottom edge of our chest CT. And at that point, I didn't have the bone films, but now I've gotten the femur films on this person. And you can see that there is this patchy sclerosis, mostly of the distal femur and the upper tibia. And this was also true on the other side too. So we have classic bone finding symmetrical widespread sclerosis. So that was the left. Let me show you the right, because you shouldn't believe everything I say right off. So here is the right, showing very similar pattern of patchy bone sclerosis in Erdheim-Chester. And then this person had a chest radiograph. I don't think I had abdominal imaging before, and it did show, the chest imaging we had before did show this abnormal tissue infiltration around the descending aorta and in the upper abdomen around aorta again. But we get more of the kidneys now, so we do have very nice halos around the kidneys. Now on the PET CT that I showed, it was several months after this, there was not very much activity at all in this tissue around the kidneys. So it was, this tissue might be at a fibrotic stage rather than an active inflammation stage. Therefore, it wasn't hot on PET. So completed the imaging a little bit, and I'll post these new exams for the Erdheim-Chester case that I sent a few weeks ago. Okay, and then I want to show you this very interesting case of a man who got short of breath and presented an outside institution with this diffuse lung disease. This is the earliest radiograph we have on him. He's got all of this stuff throughout both lungs. And this is what it looks like on CT, just tremendous amount of consolidation here. And he was bronchoscoped, and this was hemorrhage. So this was hemorrhage, and there was some abnormal serologies, and things did not go well for him. So the initial imaging was on July 22nd, and he died a day after this radiograph. He died on July 27th, and he went to autopsy. At this point, he's got diffuse lung disease. It seems to be more uniform than what we had before. He's also got some probably pneumothorax. He's definitely got pneumomediastinum and subcutaneous emphysema. We thought this might be pseudopneumothorax, and maybe it is. Can't really tell. He did go to autopsy, and he had an extensive pulmonary hemorrhage and ARDS and vasculitis. So this fits with GPA, and that's the diagnosis, although it's possible that he has some other vasculitis. So this is a rapid descent from in terms of GPA. I've never seen anything kill people like this in about 5 days, but that's what it was. His sinuses were normal. He did have kidney abnormalities consistent with GPA. So GPA going on to ARDS, pulmonary hemorrhage. And then I wanted to show you this phenomenon. I hadn't seen this until Greg Kitchka in our department pointed this out to me. This man had a calcification that was seen in his left hilum, and got this CT scan around that time. And it does show this little piece of calcium here. So it's very short, It's very discreet. People were thinking that this is calcified thrombus. This thing actually appeared after he had removal of a catheter. And so if we look at the coronal view on this thing, you can actually see that the shape of this calcification here is tubular. You can see we're looking up the lumen of it right here just because we happen to get the right orientation. This is not a motion artifact. This is an actual calcification with a lumen. And this is a calcified fibrin sheath that came off his catheter when it was pulled out and then embolized to his left pulmonary artery. So this is a calcified fibrin sheath. This is a phenomenon I was unaware of, but anytime there's a tube or a wire for, say, a pacemaker or defibrillator in place for a while, fibrin will form around it, and then that fibrin can calcify, and when the catheter is removed, it can be stripped off, and in this case, it actually embolized. The reason I'm showing you this case, which is from a couple of years ago, is that this week, a different patient had a catheter removed from the right jugular or right subclavian vein. And when that catheter was removed, there was this calcification, this linear calcification that made people think it was a catheter fragment that was still in place on CT scans, but was not visible on the chest X-ray, despite the fact that on the chest radiograph, you could see the catheter before it was removed. So the catheter itself is visible. This was a white streak that looked superficially like a catheter, but was actually probably a calcified fibrin sheath. In that case, it didn't. In the current case, it didn't have a nice lumen like this to make it very clear that it was tubular. So there was a little streak of calcium. We recognized it finally as a calcified fibrin sheath and not as a catheter fragment when that catheter was removed. So have you guys encountered these fibrin sheaths before, which can, in this case, calcify and even embolize?
I've seen them in the brachiocephalic vein, but never an embolized one that I can remember.
Okay. So put it on your list.
I agree.
Yeah. Is this
I wonder if sometimes, yeah, some of the stuff that we see occasionally calcified in the pulmonary artery, I wonder if a lot of them are just flicked off thrombin sheaths. Because, yeah, like Jeff, we see them in the internal jugular vein or the subclavian brachiocephalic vein.
Mm-hmm. Okay.
That's good to know.
Yeah. Those are the cases I wanted to show.
Okay. Travis, I can go or you can go, or?
Let me go ahead because I may have to bail.
Okay.
I'm in the reading room. Okay, do you guys see a CT?
Yep.
So this is a patient, so we do a lot of lung cancer screening at the VA, and it's not the most exciting case, but I think it's one that's, warrants discussion just because a lot of these cases, are negative, and this emphasizes the importance of just reminding people that just because we have one negative study, these patients are still at risk of developing subsequent lung cancers, and we do occasionally catch them. So this patient was being followed. As you can see, he had September, March, September, so 6-month follow-up, and it was for this stuff in the right upper lobe, which had evolved and was starting to calcify as well. So this looks like it's just probably some sort of granulomatous infection there. And this also, these nodules can look ugly just because patients have underlying emphysema. But as I was scrolling through this one, he had a little cluster of stuff there, but it was actually right here when I was looking at mediastinal windows that I saw this funny thing hiding right behind the left pulmonary artery. And sure enough, when you go back, you'll see that thing that was probably there on the prior. I would have never called it because it's small, but certainly has grown. And I couldn't really tell if it's in a lymph node or in the lung adjacent to the lymph node. I think or adjacent to the mediastinum. I think it probably is just a lymph node. But anyway, it was isolated to there. So we got a follow-up and they did a PET, and you'll see that thing, I'll just show you right there. No surprise, that thing lights up like crazy right there. And that was the only thing that lit up. So they did a bronch, and this turned out to be a stage 1, essentially small cell carcinoma in that lymph node that was detected on a follow-up screening exam. And so I think this is a recent paper that's pretty good from radiology, just describing, they looked at patients from the IL cap and then looked at follow-up CTs, patients that had had negative studies. And then 7 years later, they went back and looked at some of these patients. And it was interesting that during this period, that like 21% of these patients developed new cancers. And so there are other data too, just showing that, you know, I always have to remind myself, because a lot of these screeners get boring, but in a substantial minority of these patients, you will pick up new cancers. And this just happened to be a subtle small cell. And I think this stuff was all just infectious or inflammatory in the left upper lobe. Are you guys doing a lot of screening at your respective institutions or not?
Not really. We don't have the right patient population. We do a handful a week.
Yeah, we do. Yeah, we do a few a week, but you know, dozens every day at the VA. It's where we've had a ton of these. So
it's interesting from a, like, if you think about it from a screening perspective, you're going to more likely to pick up sort of more indolent ones on subsequent screens, and the interval cancers, you know, will show up, be more aggressive ones. And I think that was written up in the NLST, where like at every time point, something like 10 or 15% of new cancers were stage 4. And, you know, usually
this
small cell are very aggressive non-small cell because
right.
they're not being visible to nodal involvement.
Right, and then this paper of the 14 that they had detected, 12 of them were stage 1 or 2 in these cases. But you're right, especially with small cell, I was surprised that it wasn't just full blown at the point it presented. So this is an interesting. This is a patient who had an attempted lung biopsy at an outside hospital. I don't remember what the primary was, but they had this nodule, you know, not in the easiest location to get to. But this was kind of interesting because they induced the pneumothorax and then went to biopsy this thing. And I'll show you a series of images here. The patient, you know, during the procedure developed sudden onset of chest pain and started to crump. And when I show you the next image, you'll see why. Now, right after the biopsy, they have a large volume of hemopericardium that wasn't present on the previous, the scout image before they did the biopsy. So this is a complication I had not seen before in terms of, you know, getting into the pericardium and into the heart, presumably in this case. But I just thought it was it's an interesting complication to show you, but it's clearly high attenuation blood. And they actually, while the patient was still in the scanner, placed a pericardial drain in and drained the blood, and the patient did well.
Can you show the needle course again for me for a second? I'm sorry.
So yeah, on this one, there's a little bit of fluid there, and so this was, like I said, this was done elsewhere. So I don't know at what point, I don't know if they were doing CT fluoro and just didn't include those images because this all came from an outside hospital, but I don't know exactly what happened here other than they said, I was reading their note and they induced the pneumothorax to try and get to this thing. So it was an intentional iatrogenic pneumothorax, and there's already a little bit of fluid here. So, and it's not even really close to where that nodule was. So I'm not exactly sure what happened in between these couple of images, but yeah, but it's clearly an iatrogenic hemopericardium from the study, from the biopsy. So not exciting probably to the people doing it at the time, and kind of interesting. And Seth, I'm glad you're on here. Just want to show this one really quick. This is a 70-year-old guy. This is a recent cardiac MR. And this guy was previously healthy. A few months ago, started developing shortness of breath, had an echo, abnormal left ventricular ejection fraction, dilated LV as you see here. Went to cath, his coronaries were clean, and they went into MR. And you can see his LV is dilated, it's thinned in the LAD territory involving the apex and anterior wall. And sure, you see some lines and trabeculation through here. And so the question is, as you might be guessing, is, you know, the possibility, even on echo, was raised whether this was focal non-compaction. And I guess I'm biased. You can see the delayed. And to me, this looks like this is just a transmural infarct with some areas of subendocardial enhancement as well in the anterior, in the septum and anterior wall. So, and there, it looks like there might have even been a little delayed enhancement here. So the question is,
why do they think it's, I'm confused. Why do they think it's non-compaction?
Why do they think it's focal non-compaction?
Versus just a classic LAD territory infarct?
I think it's because of the fact that there was comments of like increased trabeculation here. But I think, I mean, we see this all the time with infarcts.
Yeah, that's okay. Yeah, no, that's
and it was because the cath was clean. So he must have had either vasospasm or some sort of.
That's actually not that uncommon to see people. Yeah.
Yeah.
No,
okay. So you're in agreement.
Oh, 100%.
Okay. Yeah, and I'm curious too. My question, like, have you seen cases of focal non-compaction? It's one of those.
At the apex, I am extremely careful, and because it's a stream.
It should be lateral wall anyway.
Yeah, it shouldn't involve just the apex, and also the ones with that involve where you get this prominent trabeculation in the apex. I mean, there should be some sort of dysfunction. I mean, this case has a dysfunction because he's dyskinetic because he infarcted.
Yeah,
but,
right. And it's a transmural infarct, and
that are young kids who have trabeculated myocardium. Their function is completely normal. I mean, it's essentially, if it truly is non-compaction, you should have some hypokinesis at least. That those portions of the myocardium usually don't function as well. And I think that's I'm very careful at the apex.
Good. Okay, we're in agreement then. So, all right, thanks.
So Travis?
Oh, yeah, David. Yeah.
I'm surprised that 70 has clean coronaries. So do you think he might have had? I mean, why do you invoke spasm? I mean, that would.
Well, it's spasm or embolic infarct, something that. Yeah, just something other than a classic.
Yeah, it's not that super uncommon where you have someone who has a classic infarct, and they have a big troponin bump, they come with chest pain, and you go in there and there's nothing there. Something either was a small thrombus that broke up, or they had a vasospasm. I mean, it's most of the time something there, but it's not unheard of to not have a clear pathologic lesion at the time of cath.
And and infarcts are so common, and these other things, especially in older patients, are so uncommon. But people want to invoke fancy diagnoses just because the coronaries are okay at the time of cath.
Right, because you have to remember these are plaque ruptures, and the plaque ruptures initiate a thrombotic event. And if you have relatively just some, positive remodeling, and you don't have much negative remodeling, and you had a plaque rupture, I mean, it's possible that you can have a thrombus from that and not much disease that's visible on cath. Anyways, it's an interesting.
Yeah. Thing. Okay. Well, but I think it's. I think it's one of these interesting discussions, and maybe this is just something that happens more in academia, where people try to invoke crazy diagnoses more often, just because we're biased and see them more commonly.
I kind of wonder if this trabeculation in the apex is really just surviving muscle fibers when you've atrophied the rest of the wall away.
Yeah.
Left with a few fibers like this. Do you think that's
I think that's probably true, because we see this all the time with infarct.
This is not an uncommon appearance for someone who's had an infarct there. It's just not.
No. Okay, good. Well, I just wanted to throw that out for discussion. So, Jeff, that's it for me.
All right. I can show some. Let's see here. I'll start with this one. So this is just a case that Tan Muhammad shared with me. This patient has beta thalassemia, and you can see the bones are very demineralized and somewhat expanded looking. Not the worst case of expansion I've seen, but not a lot of way of cortex, and has these large blobs in the paraspinal region, even extending out more extensively inferiorly. And then these are the CT images, and we see these sort of high attenuation, homogeneous paraspinal soft tissue masses. There's even a couple associated with ribs in the chest here. And so you can see the big pulmonary artery, the left ventricle is big from high output failure. You can see the very lucid bones. But these blobs are all, and this is probably the most extensive case I've ever seen of extramedullary hematopoiesis. You can see the really dense liver from secondary hemochromatosis, and not much of a spleen in there at all. There's the pancreas there, so we don't really see a spleen. So really exuberant extramedullary hematopoiesis from beta thalassemia, which is the most common. And I think, David, you may remember, we saw a case when I was a resident in sickle cell, which is much less common.
Right.
I have never seen one like that's remarkable.
Yeah.
I've not seen them yet
That's
before.
why I'm sharing it. So,
Jeff, in terms of pathogenesis, you know, a lot of those vertebral bodies were really porous, and you could see these breaks in the cortex.
oh
So
yeah, I'm sure
the
they're
possibility of the EMH arising as a leak out of the marrow cavity of
yeah. Unfortunately, a lot of breathing, but yeah, you can see there's, as you said, very porous bone. So quite extensive. All right.
Yeah, and David, it's kind of the same thing we see occasionally with multiple myeloma too. I like the description that it just like leaks out of the bone.
Right.
So whether it's normal marrow elements or abnormal.
Yeah, so this is a case I just saw that I like. So this patient, we did a scan today looking for tracheal bronchomalacia. So this is an outside CT that was done and done sequentially. You can see this is the expiratory sequence. I think most of us would agree it looks pretty innocuous. I mean, maybe there's some physiologic air trapping. Many of there's got the diaphragmatic eventration, but the trachea looks normal. And this was just a few months ago. And an inspiration on that scan, it's always important to look at the morphology. Didn't do a great job holding his breath, but you'll notice that the tracheal wall looks normal. The cartilage is not thickened. It's not stenotic. It's not collapsed. So given this, you wouldn't really think about tracheal bronchomalacia or any other airway problem. But we did a dynamic expiratory acquisition. So this was done during forced exhalation. So we coach these patients pretty intensely to make sure they do it correctly. Let me get the right window here. There we go. And you can see just how much collapse there is of the airways, especially the main bronchi. The bronchus intermedius you can see physiologic, but this is more than normal. So this would be an example of excessive dynamic airway collapse. And it's really accentuated with the forced expiration as opposed to end expiration, which is often what we see done just routinely for air trapping. So the plan with this patient will probably be a trial with a silicone stent to see if there's any benefit. And if there is, they will typically consider doing a tracheopexy or tracheoplasty, sort of reinforcing this posterior wall. Because the cartilage itself is morphologically normal. There's no real softening of it. And you can see on the inspiratory sequence we did, it looks pretty normal.
So, Jeff, have these things been described as a flaccid posterior membrane or something like that? Because
yes,
the anterior parts seem to maintain their shape here.
Right, that's a distinction because with this process, you can reinforce the posterior wall and the cartilage is fine. And it's thought to be either weakened fibers, redundant tissue, absent fibers, sort of a multifactorial, but it can lead to central airway obstruction. And physiologically, it acts like tracheal bronchomalacia, but it's somewhat more easy. It's easier to manage in many patients because you can reinforce this wall with different surgical techniques. But this is just a nice example of a pitfall. You really have to do these forced scans. And this technique's been well described by Phil Boisel and his former group at Beth Israel Deaconess in Boston, looking at the change in caliber versus end expiration that was done a long time ago versus forced dynamic expiration. This is just a nice example. This is a 34-year-old woman who presented with some lung nodules, and I'll show you what they look like. She was previously healthy and had these both some solid nodules and then other nodules were not quite solid, the little bitty ones. But you've got a ground glass nodule there, never smoker, and then some enlarged pulmonary lymph nodes. So these didn't go away. So, and here's another sort of hazy one down on the right base. So one of these was biopsied, and these ended up being maltomas. She did not have connective tissue disease or any immunodeficiency or anything that put her at risk. But we've seen solitary nodules presenting as maltomas, and in this case, multicentric but confined to the lungs. And she was treated with definitive chemotherapy and has been disease-free ever since. But sometimes they don't even treat them. If they're indolent, they will sort of just leave them alone for a long time until they decide to start acting bad. But this is a younger patient. Usually I see them in middle-aged patients with Sjogren's syndrome or something else. But this is maltoma. This is a case I think some of you may have seen. This was a trauma, motor vehicle crash, had some injuries, and we had I have some follow-up imaging on this one. So on the chest CT, sort of right near the diaphragm was this little flap right there, and there had been some injury in that general vicinity. So with the fact that we thought this was probably going to be a smoke artifact for a couple of reasons. It wasn't very dense, and it's kind of wispy here as we've described. And then we also were fortunate to have some delayed images because for the abdomen, and you don't see it in that area. But the good news is, if you're not sure with these, the management would not to do anything, or at most get a follow-up scan in a few days. And they got a scan a couple of days later, and you can see that area is fine. There was a plaque there, so you wonder if maybe that had some slow flow related to the plaques and turbulence. But just a mimic of an intimal tear with smoke. This is another good case. I think it's a good teaching case. So this is a middle-aged woman with an endometrial carcinoma that involves some of the retroperitoneal and pelvic nodes, but had no chest disease. And this was her just follow-up CT scan. And what had changed, and I didn't save the old one, but this lymph node here, sort of in the anterior scalene region, went from not being really visible to this somewhat plump node. And you'll see there's also another node sort of in the supraclavicular region. And going back to anatomy, we remember the thoracic duct, when it comes up, will cross over and drain into the brachiocephalic vein, often in this general area. And this is a nice example of a Virchow's node. And I pulled this, if I can pull it up here, right from the New England Journal. A nice example of a clinical finding of a Virchow's node. This was, I believe, from a GI cancer, gastric cancer, but our case is a pelvic cancer, and it has been described, and I've seen it in with an ovarian cancer as well. So it's just an important place to look with these intra-abdominal malignancies, and you'll see there's really no disease. You don't see any mediastinal disease, so presumably it just gets access to the thoracic duct and works its way and bypasses all the nodes in the mediastinum. She started to have some, you can see she had disease right here, which is about where the thoracic duct would start to start to constantly form itself there. So
it looks like there may have been a small retrocrural node on the right, and you can follow the thoracic duct up much of its course. Yeah, right there.
And that, I think that may be the cisterna chyli. I'm not 100% sure, but sometimes, yeah, you'll see that there, and you can follow the duct up.
And you can
little thing.
Yeah.
Yeah, you can follow it up. But this one I thought was a really nice example. And then I don't have tissue confirmation, but I do have a PET that confirms what we know.
Oh, so was that the cisterna chyli, or was that thing slightly hot in the retrocrural space?
I believe it
on that PET.
Cisterna chyli. Yeah.
Oh,
Hard to say there. It's kind of a liver background, but yeah, I don't know.
Yeah.
But yeah, you get these skip metastases, and it's just a good example of that.
Yeah.
This is a really cool case because the etiology. This was a consult I got from one of our other hospitals from a pulmonologist. So this is a 35-year-old woman. She is 5 weeks pregnant, had in vitro fertilization, and developed acute shortness of breath and hypoxia. Was brought to the emergency department, and they did a CT angio. Had no pulmonary embolism, but had this CT that shows peripheral septal lines. And then as we go down, you'll see some dependent consolidation and ground glass opacity. It's a noisy scan, but you can see all the findings here. No pleural effusion. All her troponin and everything else was normal. Her P was a little big, but she was very hypoxic. So I think many years ago I showed a case of this in an 18-year-old woman who had started smoking. This woman is a never smoker or is not using any other drugs, but the only medication she is on is prenatal vitamins, and she's on a progesterone injection as part of her IVF to maintain the pregnancy because she's only 5 weeks and a few days along. And so in talking with the pulmonologist, we threw out the possibility of an acute eosinophilic pneumonia because it can look like edema and infection, sort of the consolidation in septal lines. It looks just like my case of the 18-year-old who started smoking. So they did a BAL, and it was something in the range of 45 to 50% EOS. So it's clearly an acute eosinophilic pneumonia. But what I didn't know, and I found this out later, was what they presume is the inciting cause. And this is an old case report from 2004 in a reproductive medicine journal. And you can see associated with intramuscular administration of progesterone. And in this case, it was another one that had a very similar preparation in that the oil base is a sesame oil. And so this patient, you can see, had a radiograph that would correspond to what we see on CT. And they actually had another case here that showed some peripheral consolidation. So this is that luteal phase support progesterone. So they are able to switch to a different preparation. So it's another form of excipient lung disease, but this case not really from illicit drug use, but rather from normal medication. So they stopped the progesterone, gave her steroids. She's all better.
They still use sesame oil, even today?
Yep.
Wow. Okay.
Wow, that is.
I wonder if she's got a nut allergy too. She should probably stay away from peanuts.
Well, peanuts aren't nuts; they're legumes.
Yes, but there's a lot of cross reactivity with real nuts.
Yeah, I think it's a fungus on the peanuts. Who knows? But yeah, I don't know. As far as I know, she had no allergy. But yeah, it's just interesting, and you wonder if there's some there must be some sort of microembolism in the lung that triggers this.
Yeah, I almost wonder if it was going to be like a fat emboli.
Yeah, no, this is exquisitely steroid responsive.
Wow.
Very cool.
Yeah, that was my fun.
I'm going to have to stop injecting peanut butter. All
right. Speaking of injections, this will be my last case, and this is a really nice example of this. So this is an elderly patient who has some compression fractures and needed some help. So this is a vertebroplasty, and you can see at this point they've gotten access to the bone, and they haven't started quite injecting yet. And I see if I can get these in the right order. But you can see here they're doing 2 levels, and they're injecting. And what wasn't seen right away was this little tiny wisp coming off this. I think this was like T7 and T8, the higher vertebral body. And if we go later on, you can see there's this little stream of dense material. And then eventually towards the end, it was observed. Let's see if I can find a better one. You can see they took a spot of it going up and then arching over. So it looks like it's gained access to the azygos or hemiazygos. So they contacted interventional radiology to see about if there's anything to do, and they wanted a chest CT angio, but I was concerned that if we gave dense contrast, we would end up obscuring anything, and then I don't know if we really need it. They were concerned there may be adherent thrombus, and that was, I think, going to drive a mechanical embolectomy. So instead, we just did a routine chest, and we did a very delayed phase, and it actually worked out quite well. You can see contrast in the vessels, but you can see this cement. It's sort of like a string of cement going into the right lung. It's kind of hanging out, stuck to the wall, goes out a little bit, and then you can also follow it up the azygos vein. If I make a sagittal, we can probably see it pretty well. But you can see it coming right out of the vertebral body and just going right on north here, and then looping through here. And it looks like it broke off in somewhere, and then that's what embolized into the lungs. So a cement embolus, sort of, but rather than a blob, it's more of a string. There you can see it coming through the pulmonary artery and kind of coiled around. Almost looks like coils.
So this is going to actually help the posture here, and these are probably weight-bearing views of the azygos vein for the first time ever.
All right. Okay. Well, that is what I have this week. So thanks, guys.
Thank you.
All right. Talk to you later.